So thank you so much for allowing me the opportunity to present some very long-standing work that has taken me about and my colleagues about 8 years or so to put together. I've been working in Malawi for about a decade now, and I'm looking to present some long-standing ongoing work with multiple partnerships, multiple collaborators. I'm only listing Dan and David here because they've been the primary collaborators for the second and the third portion of this long-standing project. But I think my entire slide would be overwhelmed with the number of people and institutions and partnerships that have made this work possible and that continue to make it possible as we expand into new territory in the next 3 to 5 years on this. So thank you. So I'm going to just quickly start with the summary and then like the motivation, and then I'll give you some background on where we came up with the study design, how we came up with it, and then present some like trajectories of work. Each one of these pieces actually can be its own standalone, but I think together it's nice to have this opportunity at a seminar where I can present the entire picture from start to finish in terms of short-term outcomes as well as some longer-term outcomes that we've been investigating over the past 4 years. So just a quick summary. We conducted a randomized control trial with pregnant and postpartum women where we provided improved access to family planning and reproductive health services to women who were either pregnant or immediate postpartum at the time when we recruited them. And as part of this intervention, we provided women with counseling, we provided them with transportation, and we provided them with reimbursement for side effects, and all family planning and reproductive health services that were available at our partner clinics in Malawi. And the impact that we are trying to assess is not only the immediate health utilization impacts of this intervention packet, but also the longer-term fertility, health, and social and economic well-being impacts that this intervention and this trial is conferring to women. So I'll try to give an overview, but this is kind of like the summary, and then I'll get into each of these components as we continue to discuss this study. So I'm also going to give a quick preview of the results in case people want to like maybe I'm putting the cart before the horse, but I think it's important to just maybe say where we're going down in this discussion, which is women who received our intervention over a 2-year period. We found them to use contraception more, so particularly long-acting and reversible contraceptive methods. These women were more likely to utilize contraception immediately following their last birth. But the key important impacts that we see go and extend beyond health utilization, which I think is particularly important in the reproductive health and just global health space more generally, which is women in our intervention group were experiencing a lower risk of short birth spacing. And I'll explain why this particular outcome is important, because it also feeds into downstream cascading outcomes like women's employment, women's work, and women's labor force participation, which we'll also discuss, because women in our intervention group were more likely to be employed 2 years following our intervention. They were more likely to work in wage-earning labor. And something else which was particularly important, which actually just recently got published, is that children of the women who received the intervention also experienced positive health, human capital, and cognitive development outcomes. So we see that what we're doing is we're like going to try to document the trajectory of this intervention, this multi-component, longer-standing intervention for both women, children, and their families over the 2-year period where we are assessing it. And I think that the key takeaway, if we have to have a key takeaway, is how improved access to family planning and reproductive health interventions and services not only have impacts on short-term outcomes like health utilization and care seeking, but they also have intermediate fertility and health outcomes, and also broader economic impacts, particularly on social and economic well-being for women, children, and their families. So maybe I can now take a step back. Now that there's a preview, I can maybe take a step back with the motivation for this study. I think it's needless to say if we've been turning the news on, not like both locally in the US, but also globally around the world, how family planning and reproductive health has received significant attention, not only in academic spaces, but also in programs, policies, advocacy discourses. I think we can trace in the global arena, we can trace the idea of family planning as a fundamental human right back to the 1994 International Conference on Population and Development that was held in Cairo, where family planning and reproductive health services were put on the map not only as a means of population control, which was this old like historical narrative on like the use of family planning and reproductive health services for population control, but moving away from that discourse and that those implications of that discourse to sexual reproductive well-being and sexual and reproductive rights. And since the 1994 conference, and this is the 30th year anniversary of the 1994 conference this year. So there are probably a multiple events that you might be informed of or engaged with when it comes to like the UN and UNDP's holding a number of events, UNFPA, who are custodians of the 1994 Program of Action. There has been a lot since 94 to really think about how to promote sexual reproductive health and family planning within the global development agenda, not only for its own intrinsic value, where family planning and reproductive health, the idea of women controlling their own bodies, bodily autonomy, and is as key, not only thinking about reproductive rights and reproductive justice, but also how family planning and reproductive health can play within the broader development discourse. What role do these services and what role does this sector in health have in thinking about broader social and economic well-being, not only for women, but also for their families and for communities in aggregate. Related to this, so at the micro level, we can think about how the decision when to have children, how many children to have, they're fundamental and intrinsic, not only to women, but also to couples, to their families, and to communities. But we can also think about how those decisions cascade and aggregate when we think about the impacts of these decisions of birth spacing, of timing, fertility. These are fundamental to social and economic the social and economic fabric of any community, of any society. And there have been multiple discourses on the role of fertility, and particularly the transitions that we have observed around the world regarding fertility, and how those transitions in population change contribute to social and economic outcomes. So the idea of the demographic dividend, whereas we see population transitions and particularly fertility decline over time in countries, how that plays out to allowing women and children, so women to engage more in the labor market, to be able to engage more and receive more skills, stay in school longer. So there's human capital implications, there's health implications, and there's also economic implications for women and how those implications cascade onto other members of the household. And when you think about this in aggregate, this idea of the population to development nexus, this connection between population and social and economic development, has been theorized and has been examined in multiple spaces, not just in economics, but in sociology and history and in multiple other spheres, academically as well as programmatically. And so the demographic dividend idea is very much of a macro level. So we're thinking about these with like aggregate populations and in countries. But one of the things that we observe is how fertility and fertility decline has changed and how it has varied across regions and across countries. Like there's been multiple sources of evidence on how in sub-Saharan Africa, fertility may have declined at a slower pace or might have even stalled in multiple countries. And while that might be true in aggregate, we still see a lot of heterogeneity and variation when we start disaggregating those country-level trends and start looking at sub-community, sub-regional, or even individual level trends. So just as an example, Ethiopia has the total fertility rate in Ethiopia is around 5 or so, if I recall the last UNDP numbers. But when we look at Addis Ababa as a city, Addis has been well under replacement rate, so well under 2.1 children per woman for multiple decades. And so there's a lot of variation even within country as to how women, couples, and families are actually thinking about timing, spacing, and deciding on the number of children that they want. Particularly as we see the opportunity cost of childbearing change for women over time within spaces and within places. So at the individual and at the household level, we still might observe demographic dividends playing out, these mechanisms and pathways through which changing decisions around children and how those affect human capital attainment, investment in households, and social and economic capital, how those change can be observed at a more granular level than necessarily at an aggregate level. So we're interested in that variation, and the study contributes to that discourse and that literature. So in parallel, something to really also motivate the design of our intervention is that the WHO recommends that women wait for at least 24 months after a live birth before attempting another pregnancy. And this is coming from cross-sectional and correlational evidence on how women who have short birth intervals, so birth intervals between like less than 3 years, if we think about interpregnancy or interpartum intervals, from the last birth to the next pregnancy of 2 years, birth intervals like 2 years plus 9 months, so roughly 3 years. Any birth intervals that are less than 3 years, we observe that women who have those short birth intervals also may be at risk. The association between maternal and child morbidity outcomes and mortality outcomes with women who have short birth intervals tends to be high. So there are some associated risks from short birth spacing, not only for women, particularly due to maternal recovery, due to the short lag, and especially for women who may have had complicated births or pregnancies in the last birth, may be at higher risk for subsequent complications and especially and risk of morbidity for their subsequent birth. Children also may be affected by mothers who have short birth intervals, particularly when we think about how investments across children might change, how women who are in the stages of recovery might be like underinvesting or maybe be able to care less for children. And then there are also some biophysiological impacts or associations that we have observed in terms of child health. This recommendation, coupled with the general observation that we see how there is a demand for women and couples to better space and time pregnancy. A lot of the literature to date has focused on countries and contexts where we thought about limiting pregnancy, where women and couples may just want to have fewer children. But in sub-Saharan Africa and in multiple other contexts around the world, the issue for women tends to be more around timing pregnancy. When do they want to have their next child? A woman and couple might decide, I want to have 4 children. That is what I want, but I want to be able to space my children more such that I may be able to recover and such that I may be able to also buffer some of those costs before I think about my next pregnancy. Often when we do qualitative field work with women and ask women in sub-Saharan Africa, and particularly in my context in Malawi, we often hear the anecdote that women say, I want my next child when my current one can walk. And that is interesting because that when children start walking is roughly about that 3-year period between when women had their last birth and when this child can start walking so they can think about their next pregnancy. So it kind of very much aligns with the desire for timing and spacing pregnancy aligns with a lot of the broader guidelines and recommendations that come from the WHO, these international institutions. And so how can we think about facilitating and allowing women and couples to achieve this optimal timing and spacing of pregnancy for themselves? And that's where family planning and reproductive health services come in. So family planning not only can reduce the risk of unintended pregnancy where women either did not want the child that they're pregnant with, or they wanted the child later, but it also allows for more effective birth spacing. Great. So when we look at the impact of family planning and reproductive health interventions and programs around the world, we actually find quite a lot of mixed observation evidence from observational studies. The impact of family planning on not only contraceptive use, but also when we think about this cascade onto fertility, spacing and timing of pregnancy, maternal and child health, and social and economic well-being, those links are actually well theorized, and they've been theorized since the 1960s in economics with Gary Becker and Easterlin and a whole lot of other folks. But when we actually look for empirical evidence to verify and ascertain those linkages, we actually have very limited and mixed evidence from observational studies. There are actually very few high quality interventions especially in low and middle income countries that actually show a lot of these links, particularly links that extend beyond just first stage utilization outcomes. It's not just about contraceptive use and about healthcare utilization, but how did those programs actually impact outcomes beyond those first stage utilization outcomes? Most of the literature centers around two quasi-experimental studies, the MATLAB study and the Navrongo study. So MATLAB in Bangladesh, where a demographic and health surveillance site was established in the 1970s, and there were villages that received a maternal and child health and family planning program and villages that did not. Similarly, in Navrongo in northern Ghana, there were communities that received a family planning intervention in the early 1990s and communities that did not. However, one of the challenges is about where the communities that received interventions were placed. One of the big challenges in inference, in causal inference, is places that receive interventions may be very different than places that do not receive interventions before the intervention was rolled out. So it's very hard to attribute any differences that we might see in outcomes due to the actual intervention. We want to be able to attribute cause of change in outcomes to the intervention, but if there were already differences to begin with, it's very hard to make that claim that places that got an intervention or a program are different from places that did not. And observational evidence really gets challenged, particularly because it's very hard to make those comparisons. And given the amount of funding and programmatic import that it is to be able to identify those impacts, getting high quality causal evidence in this space is really, really important, particularly for informing policy and programs. Most of the interventions that we have observed often stop at just thinking about utilization also. So the timeline for how long we see impacts also tends to be pretty limited, with interventions that stop observation after 1 to 2 years. And one of the problems is that for as much as health programs and health policy interventions often tend to lump or package together family planning with other maternal and child health services, oftentimes, for all important purposes, we tend to see women very infrequently in clinics and in health facilities, so we want to be able to give them as many services and give them the option to receive as many services as possible when we see them. So family planning often tends to be integrated with other maternal child health, reproductive health, and also child health services that go well beyond just family planning. But in doing so, what happens is that it becomes very hard to disentangle any impacts that you see from that program for family planning relative to other services that might be available. So all is to say, there's need for more rigorous impact evaluation and trials of family planning interventions specifically. So what did we do? This is an experiment, a field experiment that we conducted in urban Malawi, in Lilongwe, the capital of Malawi. And in this study, we recruited in 2016 and 2016, 3 types of respondents in households in Lilongwe. The key respondent for our study was an eligible woman who was aged 18 to 35, who was married at the time of recruitment, living in Lilongwe. And here's a key eligibility criterion, that they were either pregnant or immediate postpartum, so within 6 months of having a child at baseline. And the reason why we recruited women with this eligibility criterion is because our interest was to be able to see when do women have their subsequent child. So we're picking relatively younger women of reproductive age, between the early ages of reproductive age, 18 to 35, these women have not necessarily completed fertility. They've not necessarily had all the children that they would have wanted over their reproductive lifetime. And so we're looking really to see, can we introduce an intervention that allows women to space and time their next pregnancy? So we follow women for long enough to see whether they actually meet that WHO criterion of that guideline of 2 years of spacing from the last birth to the subsequent pregnancy. In addition, we also recruit a financially knowledgeable member of the household because we also measure a wide array of outcomes related to household consumption, household income, expenditure. For anybody who's familiar with the demographic and health surveys, the DHS, the demographic and health surveys, are these large-scale nationally representative surveys that are done in over 80 countries worldwide. And they're done every 5 years for a sample. So they're funded by USAID. So for anybody who's looking for a great resource, because they're funded by USAID and taxpayer dollars, they're publicly available. They're a fantastic resource. This study, the survey instruments that we used are actually the DHS survey. So we're able to make comparisons with a nationally representative sample, even though we're running a smaller scale trial. And we also have power to be able to follow these women and these households longitudinally, which is a real value added, because we can see how things are changing over time for the same women, for the same children, for the same households. So we recruit an eligible woman, we recruit a financially knowledgeable member of the household to understand about like household well-being. And then we also recruit all children of the eligible women who are under the age of 6 at the baseline, at the time of baseline. So how do we actually run the experiment? So we did a recruitment and screening in multiple areas and multiple sub-communities and neighborhoods in Malawi, in Lilongwe. And then we screened about almost 12,000 households, 11,500 households. And we were able to identify 2,143 women at baseline who were recruited in the study who met those eligibility criteria. How do we get from 12,000 to 2,000? It's because of the pregnancy and postpartum criteria. Only about 20% of women in any household were identified to be pregnant or postpartum. So that was one of the real criteria that shrunk our household screening from about 12,000 to 2,000. And then following a baseline survey where I asked women about their current contraception, use of contraception, their fertility and fertility preferences, their childbearing preferences, what their relationships with their husbands and their partners and their communities. We asked a lot of questions about women's empowerment. And then we also measured women and children for anthropometric measures. So we measured the height and weight of all women and all children under 6. And we also did an anthropometric measurement of anemia. So we took hemoglobin, rapid testing of hemoglobin, because anemia is a real risk factor, especially for new mothers for subsequent pregnancy. So women who are anemic are at higher risk of maternal morbidity outcomes, especially if they're trying to have a subsequent child within a short birth interval. So we were measuring hemoglobin, not only for women, but also for children. So then following the baseline survey, we randomized women into 2 groups, like households into 2 groups, a treatment group and a control group. And then for the treatment group, we provided our package intervention for 2 years. So each woman in the treatment group, in the intervention group, received our package of services for a 2-year intervention period. And we conducted follow-up interviews every year, annually. So the setting is Lilongwe. On average, the total fertility rate in Lilongwe is lower than in the rest of Malawi because it's a capital. We often find in most parts of the world that urban areas, particularly cities and capitals, tend to have lower fertility than rural areas. And this is no different than in Malawi. Lilongwe has a total fertility rate of about 4.2 when we started the data collection, which are compared to about 4.5 in the rest of the country. Interestingly, contraceptive prevalence, the proportion of women who are using a contraceptive method, is pretty high in Lilongwe. This also reflects a trend where women in urban areas tend to have better access, but what's particularly important and salient about this statistic is that our baseline starts pretty high in Lilongwe compared to if we had done this study elsewhere. So we're already starting with a sample that has relatively better access compared to other contexts. This is important, especially when we think about what the implications of our impacts are for generalizability. If we were to think about what the import of our results are for other contexts, I'm happy to speak about what the baseline means here. This is the timeline that we had. We had recruitment and baselines from September 2016 to 2017, and then we had a 2-year intervention rollout period with annual surveys following up. So maybe I should give a little bit more information about the actual intervention. So following the baseline, after we conducted a baseline interview, women who were randomly assigned to the intervention group, received 3 components, a multi-component package for up to 2 years following their baseline. The first component is that they received up to 6 counseling visits at their homes by trained family planning counselors. Each of these components, I just want to note, was actually designed and developed in partnership with the Malawi Ministry of Health and the Reproductive Health Directorate of Malawi, who actually worked and collaborated with us to develop the counseling materials, to develop the design. All of our work, and this is why I said in the very beginning, there are way too many partnerships to list on one slide. But because we were embedded and working with communities and the ministries from the onset, it was particularly important for thinking about how the results and implications of this trial can help to inform programs and policies that the ministry is already rolling out. So what we were able to do was actually use family planning counselors who were trained nurses from the Kamuzu College of Nursing in Lilongwe, and they were trained by a master trainer from the Reproductive Health Directorate, the reproductive health unit of the Ministry of Health in Malawi. So we were able to get the curriculum and also the trainings that family planning counselors in Malawi typically get. So these women in our trial are actually getting the same type of counseling materials that women in the public sector in Malawi would otherwise receive. They're just getting it at home, and they're getting it more frequently over up to 6 times over a 2-year period. The other component, which was really key for us, was transport. One of the things that we realized very quickly is, particularly for women, and I think this would resonate a lot with women who've had children and particularly young mothers, one can think about how to provide like the best of preventative care, but unless there's effective transport or means of getting there, especially with young children, like women just would not avail themselves of those services. Like even if they had a latent demand for family planning, and even if they knew that family planning would be an important service for them to receive, if they could not get there, it's like that was a real barrier to access. A lot of women were like, I have a 3-month-old, they may have colic, and there's no way that I would be able to go and get contraception, even if I wanted to, because I'd have to take 2 matatus and a bus and walk about 500 meters. It would take me easily an hour and a half to get services that I know I would have otherwise received. This is like a general trend around the world where we often see women disappearing from the health system until child vaccination schedules kick in. But by the time child vaccination schedules kick in, because women often tend to be completely physically and cognitively and emotionally invested in their most recent birth, by the time vaccination schedules kick in these areas, it might often be too late because women's fertility might have returned. They may be at risk of conceiving again, and oftentimes women come back and they often are pregnant again, even if they didn't want to be, because they didn't realize that fertility could have returned so quickly, even before they could have received services, particularly family planning. So we provided, for our women in our intervention group, a door-to-door transport service. So I mapped out a full network of all the taxis in Lilongwe. So if anybody needs a taxi in Lilongwe, I know them all. And so we were able to work with the taxi services to actually pick up women on demand. So women would call or set up an appointment with our taxi service in up to 24 hours in advance. They would be picked up from their neighborhood and taken to a partner clinic, the Good Health Clinic in Area 10, who we partnered with for the duration of our study. And this clinic was picked because they are PSI, Population Services International, socially franchised clinic. They have very high quality of services. And so one thing which we were doing is that we were controlling for the supply side. We were keeping the supply side fixed so that all women who were part of our study could avail themselves of these services for free at their demand and over the entire 2-year intervention period. So we really wanted to see the demand response from really providing the best effective supply that women in this context could avail themselves to. So women were taken from their homes, if they chose, to the Kauma clinic, which was on average about 15 minutes to 20 minutes of a drive away from their neighborhoods. Now, that's not that far. I mean, if we actually like do a distance map to map, it was about like 2 kilometers in terms of distance. But the problem is that like 2 things. Women would like the transport, the public transport component, if they actually receive public transport, would take them about easily an hour to travel that same 2 kilometers because they would have to go into the city center and out. It was very radially mapped. The second thing is a privacy concern. Even if services were available at more proximal locations in their communities, women were often concerned about privacy. Family planning tends to be pretty stigmatized, particularly the use of contraception in these contexts, and women did not want their neighbors to know that they were contracepting. So even if women could go more locally, they actually preferred to go to our family planning clinic because it was private and further away and nobody else would know that they were receiving services. And then the third component was full reimbursement. So for the 2-year period, women in our study received complete coverage of all family planning related services. This included methods, this including consultation fees, lab tests, and also the insertion and removal of long-acting clinical-based methods. One thing that we also provided that we actually highlighted was for the treatment for contraceptive-related side effects. This is because in our context, contraception is often provided for subsidized or even free of charge by the public sector. But if women receive or experience a contraindication or contraceptive-related side effect, that often tends to be earmarked as a medical expense, and then women have to pay out of pocket for that coverage, for treating that side effect. So a lot of women were, like, given the perceptions around side effects and the fears of incurring a contraceptive-related side effect, women would not start or want to start a contraceptive method, even if they had a latent demand for it, because they were afraid of incurring a side effect and then having to pay out of pocket for it afterwards. So we covered all of those related costs related to contraception and family planning. We had a field manager who was posted at the clinic at all times to be able to receive women. Women would go in and they would receive any services that they chose. And then at the end of the service, the field manager would go in on the woman's behalf and cover any costs. So there was no financial or monetary transaction that women had to incur. It was not like a reimbursement where we would like women would have to front up the costs and then we pay them later. This was all to minimize coercion and to be able to respect women's choices in fear, because I think we can spend a whole other seminar talking about the very problematic history of coercion in family planning and reproductive health. Both in the US as well as abroad. So I think these were the 3 components that were part of this intervention. So this is the actual brochure, and some of the content in Chichewa that we would provide. And as you can see on the right side, on the very right panel, these were the different methods that were being discussed by counselors. In the middle panel, this is actually about how do you actually go and connect with the clinic. We would give them information about the importance of contraception for like child spacing and timing. And then in the very left column, it was about like return to fertility. A lot of women did not know that they could get pregnant as soon as 3 weeks following the birth of their last child. Because for a lot of women, especially women who are not exclusively breastfeeding or using or lactationally amenorrheic, they often like return to fertility is up like can be as soon as 3 weeks to 4 weeks following a pregnancy. And a lot of women did not know that. So they weren't thinking necessarily about contraception or about family planning because they were still focused on their most recent delivery. This is the taxi, one of the taxis that we used to take that would drive from women's homes to to the clinic and back. One of the things that was particularly important for us is that, and that I forgot to note, is that all taxi drivers in Malawi are male. I've yet to find a female taxi driver. And because of the stigma around women getting into a car with an unknown man, we would always also have a female enumerator or female field manager in the presence of the taxi driver. Like by the end of the intervention, everybody knew our taxi drivers, and there was less stigma because they'd been accustomed to taking the taxi. But in the beginning, it was very important to make sure that we had another woman present so that women were not looked like there was a lot of social stigma and also individual concern around getting into a car with an unknown man. This is actually the Karra clinic. This is a pretty typical scene where we have several women and their children actually waiting for services by the clinician. The Karra clinic is actually a very high quality clinic. Contraceptive stockouts are almost never. There were clinicians who could provide not only counseling, but also additional clinical care, including the insertion and removal of services. Very common, very high quality clinic in Lilongwe. So we conducted this intervention over a 2-year period, and then we started collecting data annually. We would go back to each of these households, both in the intervention group as well as in the control group, to see how things had changed. And we would document utilization of the intervention among the intervention group. We would document their experiences, and we also would document key outcomes related to contraception, subsequent pregnancy, and also social and empowerment outcomes of interest. So our primary outcomes that we were powered for in this study were first stage outcomes related to not only contraceptive use, so whether women were using or not using contraception, but also method mix. Were women changing among women who were using? Were they changing the types of methods that they would have liked to receive and were receiving at our clinic? And then we were particularly interested, based on the WHO recommendation, of this birth interval. So were women at lower or higher risk of a short birth interval? Were they able to achieve that birth interval based on the WHO recommendation? Because that was a key part of counseling, but also as part of the intervention. In addition, we also measured women's employment. One of the key domains of literature in the demographic dividend literature is how the opportunity cost for women changes as fertility changes. So if women are able to space and time children longer and wait until they have a child longer, then they may be able to go back to school, go back to work. These are all women who are 18 to 35, so they're already out of school. Most of them already had completed schooling, but it was definitely about thinking about work. Like, how do they change their time use? How do they change their work and their allocation to labor? And then because we measured children, we're also interested in the impact of this family planning intervention on children's physical growth. So we measured height for age, weight for age, and also measures of cognitive development, where we actually observed and measured children, how they actually physically and cognitively develop using standardized scales in the early childhood development literature to be able to assess child cognitive functioning. I'm not going to go through the empirical analysis, but basically this, I mean, the math is the math, but basically what it is that all it is that we are just comparing outcomes for women who received the intervention compared to outcomes for women who did not receive the intervention at each follow-up period. So after 1 year, after 2 years. So that, I mean, the analysis is the analysis, and I will show you graphs to explain that. But like the main takeaway is it's just a comparison of group level outcomes across all these outcomes over the study period. So one thing to note, something which was particularly important, and this is another technical note, is that in children, particularly over the time period, we had quite a bit of attrition. So one of the worries of a study that is longitudinal like this is that if we start seeing that when we try to recontact and follow up on our respondents, if people can't be found anymore. Now, people can, hopefully, people cannot be found simply randomly by chance, But if the reason why people can't be found is related to how they received or did not receive the intervention, that creates a major problem for us. Like if we see that women who were receiving our intervention were less likely to respond to us or less likely to follow up with us because they're like, oh, you're annoying. You've come back to us for 2 years. Like, don't bother us anymore. That could be a real problem because then they're differentially like attriting or not being found from the sample. But like, by the same token, women who did not receive services as part of this intervention may also be differentially not being able to be found out. So in that spirit, we did some adjustments and children were a particular worry because like women were our main identifier. They were the main respondent who we could track because we had their phone numbers, we knew where they lived, but especially as children age and start aging into school age, they're more likely to like not be found at home because we were able to find a lot of children at home in the beginning because they were less than school age. But as kids start aging, then it's harder to find them and it's harder to plan for them to be available. So we had to do some statistical modeling to be able to see, are we seeing differential attrition? Are we seeing differences in how children are found versus not found between the intervention group, children whose mothers were part of the intervention group, and children whose mothers were part of the control group? So we did like a bound analysis and selection models, and I'm happy to explain them further. So let's go to the results. In thinking about the results, let's start with contraceptive use. So on average, these are the intent to treat, like these are the actual treatment effects, where we see that women who were part of the intervention, who were assigned to the intervention, had a 5.7 percentage point higher likelihood of using contraception after 2 years of intervention exposure compared to women who were assigned to the control group. This was almost exclusively coming from an increase in modern method use. So like women were taking up modern methods in the intervention group relative to the control group, and the specific modern method that they were taking up was the contraceptive implant. So the implant, which is known as Jadel, that's the local brand, it's a 3-year contraception method of contraception, which is actually clinically inserted in the upper arm by a clinician. And a lot of women in our intervention group were more likely to take up and use the implant over a 2-year period. Something to note here is actually the risk of a short birth interval. So these are survival curves, and I can explain what this looks like and what this actually means. So the interpretation here is this blue line is the risk of a short birth interval for treatment women, so women in the intervention arm. And this red line with the confidence intervals, the confidence bands, are the risk of a short birth interval for control women. So basically, the net result from this is that women who were assigned and received the intervention had about a 40% lower likelihood of experiencing a short birth interval. So within 2 years of their previous pregnancy and delivery compared to women who were assigned to the control group. So a 40% reduction in the hazard or the risk of a short birth interval after 2 years of exposure to the intervention. This was a pretty significant result from our study. So there's a particular real fertility effect that we're observing as a result of exposure to our intervention. So when we turn to employment and labor force, what we actually start seeing is divergence here. So after 1 year of exposure, women in the treatment and the control group look pretty similar. But after 2 years of exposure, we start seeing differences where the proportion of women who are employed relative to the proportion of in the intervention group is higher than the proportion of women who are not employed. Who are employed in the control group. So the relative employment rates are higher in the intervention group relative to the control group. What's more interesting is also not only are they more employed, but they're also employed in wage earning employment. This is particularly important in a context where women often are most engaged in informal and non-paid employment in this context. In Malawi, women often are working in the informal sector. They're not necessarily paid in cash or in kind for their work. And so the fact that we are actually seeing increases in wage earning employment is pretty promising after 2 years of exposure. So this is going into that story of the demographic dividend, where women who are able to space and time childbearing might actually be able to return to work and might actually be able to work for wages relative to women who are not. And this is related to also self-employment. So self-employment amongst these women, which is actually a very common approach to work in this context, also is higher in the treatment in the intervention group compared to the control group after 2 years. So these are just the point estimates showing the graph, like the graph from before. But women in our context are 5.3 percentage points more likely to be formally employed compared to women in the control group. They're 3.5 percentage points more likely to be engaged in wage earning work. And they're more likely also, like labor force participation is about 3.8 percentage points higher. So when we start now looking at children, in terms of child health and cognitive development, we're now following the children of these women. In particular, we follow the index child. And the index child in this study is the child who the woman was either pregnant with or just had given birth to recently within the past 6 months that made her eligible for the study. So we're following that cohort of children who the women just recently had or were about to have, to see how their physical health and their cognitive development is changing. So what we see is that in terms of height for age, children are about 0.34 standard deviations taller in terms of height for age if their mothers were exposed to the intervention compared to children whose mothers were not exposed to the intervention. A 0.34 standard deviation increase in height for age is pretty significant. As you can see here on the right side, like at baseline, you see that the distributions of height for age are no different. They look pretty similar between children in the control and the intervention groups. But what you see by 2017 is that the distribution for the treatment group is shifting to the right. So this is where children are starting to, we start to see that on average, children are getting taller by about 0.34 standard deviations. In addition, by a measure of early childhood development and caregivers' assessments of early childhood development, children in the intervention group are about 0.23 standard deviations better. Like they perform better on measures of cognitive development, on an aggregate summary measure of cognitive development compared to children in the control group. And we also see that the mass is also moving a little bit to the right. Like this mass up here is indicating the distribution shift in children in the intervention group. So I think I'll stop here, but I just want to make sure that I can conclude with some thoughts from putting all these results and components together. So we conducted a randomized controlled trial, an experiment that provided postpartum and pregnant women with comprehensive access to a family planning intervention. After 2 years, women are about 6 percentage points more likely to use contraception. They're about 40% more likely to have had a second pregnancy. So like we're lower at risk for a short birth interval and short intrapartum interval. And they were 5.3 percentage points more likely to be employed. For children, for those index children who made their mothers eligible for the study, they were about 0.34 standard deviations taller for their biological sex and age, because standard like heights and weights are standardized in order, like, because we always compare children to their reference population, right? So if you ever go to the pediatrician, like when you say you're in the 95th percentile or 99th percentile, it's all standardized and comparing yourself to your sex and your age, right? Like other people of your sex and your age. So for their sex and for their age, children in the intervention group were about 0.34 standard deviations taller, and they performed about 0.2 standard deviations better on cognitive measures. And I did not show a further analysis, but when we see what are the reasons, like what are the channels by which these height and cognitive development measures are being improved, we see that the improvements for these children by these measures is driven by increased healthcare utilization, where their mothers are using more care, and also by the birth spacing effect. So the fact that their mothers are spacing their subsequent pregnancy longer seems to be channeling back to increased investments in their children, which is a pretty important component to explain these channels between fertility change, human capital, particularly for children, and social economic outcomes. So I think I'll conclude on this slide by saying that, like, I think that the policy discussions around family planning and reproductive health still focus very much on that first stage, just whether women are using or not using. But I would like to remind us that contraceptive use is not a measure of welfare. It's not a measure of well-being. It's just a measure of healthcare utilization. So if we really want to think about what the well-being and welfare impacts are of these programs, we have to think about downstream, larger, and more comprehensive measurement that actually reflects well-being. And this is what we are able to measure in this particular study. And I think, like, just to maybe have hopefully convinced folks that the results from this body of work, this 8-year trial, have effectively tried to support the existence of the demographic dividend, this idea of like population transition, and how that has economic implications, but not just at the macro level, but at the household and the individual level, particularly how these women and these households are making choices and are able to realize returns from changes to fertility and to their birth spacing and timing. And I think, broadly speaking, I think it's like from the field, this shows evidence on how family planning may not only be an effective reproductive health intervention, it's not just important for contraception, reproductive rights, and autonomy. It's really important for that from an intrinsic and intrinsic perspective. But it's also important to think about it from a longer term horizon when it comes to thinking about short as well as long-term health and economic impacts beyond just fertility. So I'll stop there, and I'm happy to take any questions from the audience. Thank you.